the kind of research that I've been doing, and overall, what has governed my research are these two questions. Trying to figure out, why do typically developing children learn the words of the language so rapidly, and why do children with language impairments learn the words so slowly? And more importantly, what can be done to accelerate their learning? So in terms of my past research, much of my early research really focused on the characteristics of new words and how those characteristics might influence the speed of learning in both of those populations. And I look specifically at these two particular characteristics that are on the slide. And overall, the story from this is that these characteristics do influence how quickly children learn words, but there's some variability to that. And that variability depends on the age, so we see different patterns when we look at kids versus when we look at adults. It also varies on the language abilities of the child, and that comes out when we look at clinical populations with communication disorders versus our typically developing children. And then most recently, I've been interested in timing. And here what I mean by timing is that when children learn a word, or really when anyone learns a word, you don't learn everything you need to know about that word with just a single exposure. So it turns out that our word learning is distributed over time, where we'll have some exposures and some experience with a word, but that's not going to be enough to give us a really rich understanding of that particular word. So then we'll have multiple encounters with that word as we move forward in life, and through those multiple encounters, our understanding of that word or our knowledge of that word will develop. And so then this brings up a really important questions and interesting ideas about how learning and memory influence that process. So if we look in general to the learning and memory literature in cognitive psychology, we see that it's really important what you can learn in the moment from that single exposure. You have to be able to pull out information and store that in memory. But then also you need to retain that information over time so that you can call that information up again when you have a second encounter with that word and integrate that information together. So that then drives my current interest, which is looking more at how this word learning unfolds over time. And this has brought me to clinical treatment, which was always the goal, as Joanna mentioned in her introduction, to get to clinical treatment. But there's lots of good reasons to study clinical treatment just to improve our understanding of how learning takes place. Since we know that learning takes place over these longer time scales, and typically learning has only been studied over very short time scales with normal adults, college students. We bring them in, we give them a very reduced subset of items to learn that are nothing like the subset of items they have to learn in the real world. And then we just look at how they retain that information over a day or maybe a week, but not over a lifetime. So by looking at clinical treatment, this gives us an opportunity from the theoretical perspective to try to scale up our models of learning and memory to see how they might operate in a real world context. And then clinical treatment is something that children want or their parents want for them. So in terms of thinking about bringing someone into a laboratory context and having them study a huge number of words and look at their learning over a long time scale, not everyone would be motivated to do that. But when we have children who have language impairments who really need this kind of treatment in order to move forward with their academics and their communication skills, they're more motivated to participate in these kinds of long-term studies. So there's an opportunity here to move the theory forward, in addition to the opportunity to understand more about children with SLI and also to understand more about how clinical treatment works. Along with that, in any kind of clinical treatment, not just with word learning, we're interested in learning. That's what we're trying to do in clinical treatment. So it's important that we take these theories of learning and think about how they might map on to how we would do clinical treatment. So where I am right now then is in creating the treatment protocol that we'll be using, this interactive book reading treatment. So this is at a very preliminary stage and really my first foray into clinical treatment research. And I've quickly learned that there are some challenges in clinical research, and so I want to highlight a couple of those. One is the lack of strong designs for preliminary stage work and how we really move from theoretical into the translational. And then also our challenge in the variability in the populations we study and how they respond to treatment. So first, I'll talk a little bit about specific Specific Language Impairment, or SLI, entails a significant language deficit in the absence of any obvious causal factors, and typically in any other broader kinds of delays. We know that it affects about 7.4% of kindergarten children. However, only 29% of kindergarten children meeting this criteria are often identified. So we have some issues here in general with studying SLI and with serving children with SLI, in that they're not necessarily being referred to speech-language pathology services, or people aren't necessarily picking up on some of the challenges they have, at least in this kind of preschool, kindergarten age range. A variety of areas can be affected. Different components of language can be impacted. And my focus obviously is on word learning. And so what we know in that regard is that our experimental work with children with SLI shows that they typically need 2 to 3 times as many exposures as typically developing children to learn new words. We also know that they have deficits in both their breadth and depth of vocabulary. And what I mean by that in terms of breadth, just the number of words that they know, at least to some minimal criteria, versus depth being more the richness of their knowledge about particular words. So we see problems in both of those domains. We also know that the vocabulary deficit tends to persist over time. So studies that have looked at children from 3 to even 21 show that these vocabulary deficits can be present across that whole age range. So it's not something that seems to be going away on its own, or that seems to be impacted by at least some of the current treatment methods, but that could relate to this issue in identifying the children as well. So now in terms of moving into the particular problems, the first one, the lack of designs. So in a preliminary clinical trial, so basically if you have this idea that maybe this manipulation could impact clinic, where do you begin? You start at the preliminary clinical trial stage. And the point here is to address key design and clinical issues before you would move on to a definitive clinical trial. So normally when we hear clinical trial, we're thinking of those randomized controlled clinical trials that are our highest level of evidence and so forth. But we don't move to that as step one, because those are large-scale designs that require a lot of coordination. And so first, though, we really want to develop our treatment and have some idea that it's pretty good before we go to that ultimate stage. So one of the key issues that really needs to be addressed early is the intensity of the treatment. And by intensity here, I don't mean loudness, if we have any audiologists in the room. So it's not how loud you yell the words at the children, but rather, in this case for word learning, I'm talking about the cumulative number of exposures that are properly administered. So it's your teaching episodes and how many teaching episodes you need to provide to the child for the treatment to be at least somewhat effective. And the obvious reason why you need to set this is that if you're giving a treatment that is not intense enough, then there's no hope of really seeing any kind of effect or figuring out if one version is better than another or so on. So this is something we need to figure out. It's standard in drug trials to do this at the preliminary stage, but it's rare that you see this in behavioral interventions and see it documented in a way that you can understand why they chose to do this at this particular intensity. So for our study, what we wanted to do is borrow some of the ideas from drug trials, since this is relatively well developed there, and see how we might apply this to a behavioral intervention. So the basic tenets in drug trials is that you want to use as few participants as possible to hone in on the intensity that you want to use. And the reason for that is that then allows you to limit receipt of ineffective treatment, so that you're not giving ineffective treatment to large numbers of children or subjects. And part of doing that then is to just identify an adequate or a promising intensity, not necessarily the optimal or the best, but just kind of to get into the right ballpark as quickly as possible so that you can move forward within that ballpark and not have to consider all other possible options. Now, one challenge here is that a lot of the drug trial literature is on toxic drugs. And it's really difficult to see the parallel between toxic drugs and what we do in the clinic. So in toxic drug trials, the way you do this is you increase the intensity until it reaches a toxic level. And then you say, okay, we won't do that, that seems bad. And you just drop back a step and do the most intense version that is not toxic. So for us, it's hard to say what would be toxic in treatment. I suppose we could do it until the child cried, and that would be one sort of definition, but that might be hard to sell to the IRB. And it's not quite a nice mantra, do it till they cry. Not really a good rallying cry there. But if we look at some of the recent work with non-toxic drug trials, this makes a bit more sense. They basically increase the intensity until you see the benefits plateau. And that makes, I think, a lot more sense with what we want to do. So the way that this typically kind of works is that you first set a threshold for your outcome. So you have to have something that you can measure that you would say, if a kid did this, we would say that was a good enough response. So for word learning, it might be they have to learn a certain number of words. Any kid who learned that number of words, we'd say they responded to the treatment. And then other kids who didn't learn that number of words, we'd say they did not respond to the treatment. So then you can plot, as I'm showing here on a hypothetical graph, we have the percent of people or children who responded to the treatment, so those ones that met that threshold. And then we can look at how that changes as we increase the intensity. So this is a hypothetical intensity from 1, which is very low, to 6, which is very high. And what you can see in the early phases, as we increase intensity, more and more people benefit from the treatment. And then we get to a point where, as we do more and more, it doesn't help anymore. So the point would be that in this particular hypothetical, intensity 4 would be good, because as we go further, we don't get any added benefit. So there's no benefit from the cost of doing more. And so then we would say that this intensity 4 is an adequate or a promising intensity of that treatment, and we can move forward with that particular treatment. So that is one of the goals of this current preliminary clinical trial, is to apply this escalation strategy to an interactive book reading treatment to identify the adequate or promising intensity for children with SLI. Now, in terms of variability in treatment response, this is another important issue to address early on in a clinical trial, is to determine what kinds of people actually benefit from the treatment. And there's a number of ways you can use this information. On the one hand, you could restrict your clinical trial to just the people who have certain sorts of profiles that look like they would benefit, or you could do more development on your treatment and see if you couldn't change that treatment in some way so that every person who had the diagnosis would improve from that treatment. But this issue also goes beyond the importance of preliminary clinical trials. In general, even when we show that a treatment is effective, it is rare that all of our treatments are equally effective across everyone who has the diagnosis. And so this has brought forward an interest in doing more tailored approaches. So it would be great if we could tell clinicians, people with this kind of profile will have a higher likelihood of success in this kind of treatment, whereas people with this type of profile would have a higher likelihood of success in this type of treatment. As it stands now, we just say, here's a good treatment, try it, see if it works for your person, take data, change if it looks bad. But it would be great if we could give some of that information a priori, so that at a diagnostic, you would have a better sense of whether or not the treatment was appropriate for particular kinds of people. So this is another purpose of our trial, is to look and see what the treatment response looks like, and if there's any factors that seem to relate to the variability that we might see in that treatment response. So I'll say a little bit about the treatment that we chose to move forward with. It's an interactive book reading treatment. The reason that we chose this treatment is that it's been used a lot in other populations of children and has been used successfully. So we've seen this used with typically developing children just as a way to enhance their vocabulary. We've seen it used with children from low socioeconomic homes where they typically don't hear as many vocabulary words or don't hear them as often as children from higher backgrounds, higher SES backgrounds. And so interactive book reading has been shown as a way that might accelerate their word learning. However, we know that children with SLI need more exposures than either of those two groups to learn new words. So it's likely that the intensity that interactive book reading is done with these populations is not going to be adequate for children with SLI. But the question then is, well, what intensity would be adequate? So that's our starting place here. So here's our group. We have data from 27 kindergarten children with SLI. We have full data sets from 26 children. One of the children missed his post-test. So in some of the figures it'll be 26 children and some it'll be 27. They're about half female and male. They were all in kindergarten, and in Kansas, you have to be 5 years old to start kindergarten, so our age range is 5 to almost 6.5. And you can see that our demographics match what we typically see in Kansas, so the majority of our children are white and they are non-Hispanic. They also, the majority of them are have parents that are currently married. And likewise for the education, it generally matches, again, what we see for Kansas demographics, where you see the majority of our group have moms who have either a high school, partial college, or a college graduate. And the pattern is somewhat similar in the fathers, except that we have a lot of missing data, and that's mostly from the single divorced homes. In terms of the characteristics, the children had to pass a hearing screening. They had to be monolingual, speaking only one language. They had to perform within normal limits on a nonverbal IQ test, which is the first line in the table. We used the self-core language score to qualify them as having a language impairment, and so they needed to be at or below the 10th percentile, although we did have one child that we misscored. So originally we thought the score was at the 10th percentile, but it turned out to be a little different once we double-checked. We used 3 different measures in this sort of bluish box to look at vocabulary. It's notoriously difficult to use static measures of vocabulary to identify children who actually have word learning problems, so that's why we used a battery. Children had to score at or below the 10th percentile on at least one of these measures, and you can see by the percentages how many children qualified within each measure. So they're in order of the ones that were the most often qualifying test. You can also see that these percentages add up to more than 100 because some children qualified on multiple measures and some only qualified on one. We then took a number of other measures that were not used to enter into the study, but were just used to characterize the children. And again, you can see that we have wide variability. So the percentages are showing you the kids who scored at or below the 10th percentile, so that might be a more problematic area, and give you a sense of where the deficits kind of lie. So you can see a lot of children had trouble with understanding spoken paragraphs, but then there was greater variability when we look at things like non-word repetition and phonological memory and so on. So for our interactive book reading, we used a paradigm that had been previously tested by Justice and colleagues with kindergarten children who were from low SES homes, some of whom had vocabulary deficits and some of whom did not. But she was able to show that this treatment was effective for that group, so we thought we would start with something that we knew was an effective treatment and try different intensities of that. So from her study, she had identified 10 commercially available storybooks that were appropriate for children that were in kindergarten. And within each book, she identified 6 target words. And this was done in the normal way that you typically identify vocabulary words. There are tier 2 words if you know that terminology. So basically they're words that seem like they would be useful in a variety of environments but are unlikely to be known by kindergarten children. And the data from her study at the pre-treatment point substantiates that. The children generally perform very low on these words when they were asked to provide a definition, but then after the treatment they did learn some number of those words. So for our study, for each child, 5 books would be selected for treatment, so they would end up being taught on 30 words, and then the other 5 books would be randomized to control, so they wouldn't actually ever see those storybooks, they were just tested on the 30 words that were in those books. And all those stimuli are available at our website. For a given treatment session, the children would typically work on 2 books in a session, so they would work on book 1, and then they'd have a slight break, and then they'd work on book 2. Typically, the sessions lasted anywhere from 20 to 30 minutes, so it was pretty quick. For the book reading, we did something a little bit different than what Justice did, and this was at her recommendation. For her study, all of the teaching did occur around the book reading, but we knew we were going to increase the intensity, and so we were concerned that providing a lot of teaching during the book reading would interrupt the flow of the story, and then children with SLI especially would have difficulty following that storyline, so then the book reading wouldn't be a very good platform for jumping off into a meaningful context. So what we did then was each session for each book began with a pre-book reading activity where they were shown a picture like this, that was just one that we found, and they would hear the synonym and the definition of the target word. They would then engage in book reading, and in some cases, depending on the intensity, there was some teaching that occurred during the book reading. And then they also had a post-book reading activity or review activity that again had a different picture, and then they would hear a context sentence that went with this picture to help them infer the meaning. And in some intensities, they would get additional teaching at that point. So in terms of our escalation strategy, we picked 4 intensities that we thought would potentially be in the right range to begin with, and we entered children in blocks of 4. So there would be 4 children, and those 4 children would be randomized to one of the 4 intensities, and then we would move to another block of children and so on. Some of the blocks did occur at the same time, so we usually did have a couple blocks going on at once. But the point of doing it that way was so that we could stop at any given point and sort of see what's happening with these intensities so that we could make decisions about whether to stop certain intensities or add a higher intensity or whatever, depending on what was going on. And again, we were following the standard pattern of identifying, having a cut point for what was a good outcome and looking at the percent of children who had that good outcome, and I'll show you those details. But first, here are the intensities that we tested. So I'm showing you the control books. Just to be clear, there were no exposures to the control books, but the treatment books are what you want to focus on. The exposure occurred within a session, so there's some number of exposures that are happening during the treatment, and then those treatment sessions are repeated over time. So it does parallel real-world word learning, where you're going to hear a word and then you won't hear it for a while, and then you'll hear it again, and then you're not going to hear it for a while, and so on. So we started with intensity 12 because this is the intensity that Justice used and it proved to be appropriate for her population. And then based on the empirical research with SLI, we looked at an intensity that's 2 times and 3 times that, based on the studies that have shown that children with SLI need 2 to 3 times as many exposures. And then we went up 4 times as well, hoping that that would be the plateau. So that was the general idea. And this shows you the extremes there, intensity 12 to intensity 48. And the red is showing you the exposures that occurred during the session. So you can see for intensity 12, it's 3 exposures that happen, 1 in the preview, 1 in the book reading, 1 in the review. And then this is repeated 4 times. So 3 times 4 is 12. not hard math, even for us. And then in the 48, you see both of those things are doubled. So during the session, they're going to hear 6 exposures, 2 in the preview, 2 in the book reading, 2 in the review, and then that'll occur on 8 different occasions. Any questions so far about the design?
Just back that slide. So during the book reading, is this extra textual talk? They came down to a marsh, or is
This is the
or is
book.
it a combination?
This is the
That's
text.
the text.
Yeah.
Okay. I'm just curious. Thank you.
Can I ask one too?
Yeah.
The control kids, were they going through the same process with non-target words, or?
Oh, sorry. Each kid got treatment. So it's within the kid, you have 30 words that are treated and 30
Okay.
words that are not. So it's all within.
Okay.
Other questions? Okay, so then we have 2 outcome measures. I'll talk first about our primary outcome measure. This is the primary outcome measure because it's the one Justice used. It's a definition task. And you can see, you just say, tell me what blank means, just what you would probably infer. And then the hard part, though, is actually scoring the definitions. Actually getting them is not so hard, but scoring them is hard. We used a scoring metric developed by McGregor that was used with kids with SLI. And you can see it's really a 4-point, but 0 to 3 scale. And this actually goes, how you score it relates to also how we developed the definitions. So the way we developed our definitions that we used for teaching, we looked at a variety of different dictionaries and pulled out the common elements from those dictionaries. So for example, for this word flashing, our definition was a sudden bright light that goes away fast. And when we looked, we came up with that because when we looked at all these other definitions, every single one mentioned something about light, and every single one mentioned something about transient, so something along the lines of sudden and goes away fast. For our definition, we made sure that we brought forward those concepts with words that were high frequency that kids with SLI would likely know so that the definition would actually be useful. But then we use it in our scoring metrics, so to get a full credit for a definition, you'd have to have those 2 concepts in whatever you said. So that's how we made our scoring rubric, was starting by working backward and saying, well, we constructed the definition to have these 2 key concepts, and then maybe for a 2, maybe only one of those concepts is there. For a 1, it could be that only one of those concepts is there, but it's the one that's not so good. It's the least telling for that particular target word. And then there were things that were just wrong. So here's some examples. So for flashing, some 0-point answers were flashlight. We had a lot of these kinds of phonological. For marsh, marshmallow was a really popular answer. Not correct. When it's dark, again, that's very vague. I mean, you could maybe read something into that, but our rule was if you had to read something into it, then you can't score the part that you're reading into it. Change. That was thought to be too vague, so even though it has the idea of transient, it's like too broad. It doesn't really implicate flashing per se. You're flashing your camera on and off, so you all know that you can't define a word with the word. But that's a nice sentence that shows that the child does have some idea of what the concept is, so that gets a 1 point. And then lights go on. On our scoring rubric, you got more credit for light because that was felt to be really core to flashing, so that would be a score of 2. And then light is on and is off and on, has the concept of both light and transient, so that would be a full credit definition.
So Holly, just another quick question. I can certainly see with flashing why light is more critical than transient. But how did you determine that for all your words? Was it just the logic of it, or
Yeah, it was sort of like when we said, well, change. Does that really imply flashing, or is that pretty close to flashing, or are there a lot of things that you could define as change? So yeah, it was more a judgment call. And some of them, both of them, we felt were equal. Some of them even had 3 elements, so that would make a difference too.
Where did you classify functions? So it groups things like use when it's dark, or see when it's dark.
So this is
Or
another
context
thing.
thing.
Sometimes kids don't do things that fit your rubric very well. So we always had actually 2 people score, and then if there were discrepancies, they would discuss them. And then typically when something came up, we added it into the rubric so that we would make sure we were consistent. So in that case, that would probably be one where there might have been a difference of opinion, and then we would resolve that. And then that one probably we would have given, if they said used when it's dark, that probably would have gotten more credit than 0 for sure.
Right.
Whether we would have put it as 1 or 2, that probably would have been part of the discussion.
Counted in some way.
Yeah.
When it was less than vague,
Right,
but still.
yeah, yeah.
Did you get pretty good interjudge reliability with 4 levels like that?
You know, we haven't computed that yet. That's still something we're working on. And then actually I should mention too that even if the 2 people couldn't resolve the disagreement, then we would add in a 3rd person. And sometimes it even had to come to the whole lab group so that we could, you know, decide where we wanted to put that in the scoring rubric, so we made sure that we continued on with that. So then for comparison with justice, we ended up counting the scores of 0 and 1 as basically incorrect, and the scores of 2 and 3 as correct. Because that matched more how she scored her definitions. Our secondary outcome measure was picture naming. This was administered during the treatment at 4 points during the treatment. And again, it's probably what you would expect. We show a preview picture. We give a little bit of a lead-in sentence because the pictures are kind of broad and maybe don't lead you exactly to that word. And then if the child provides the correct answer, they would get credit for that. And we would allow some variation here, so misarticulation like waffle for ruffle, that would be counted as correct. Or also adding on morpheme, so if they said ruffled instead of ruffle, that would be fine, or ruffling instead of ruffle, that would be counted as correct too. And these were administered, in all of the intensities, they were administered 4 times. And what the table is highlighting is that, of course, as someone is moving to a higher intensity, they pass through the lower. So this gives us some added data, and we explicitly picked our test points so that we could capture those. So we have intensity 12 basically for all of the subjects because they all pass through that, and then 24 for some of the subjects because in the higher intensities you would pass through that one, and then likewise 36 for 2 of the groups, and 48 only for the 1. So first we'll look at this effective intensity, and we'll look at the definition outcome. So how did we define a good outcome? Well, we started out with one definition based on justice, and then we checked it relative to our own data. And what we ended up doing is saying that if you learn 5 or more words or provided a good definition for 5 or more of the treated words, that would be a good outcome. And that's similar to justice's definition, which was 4 or more words. We came up with 5 because we looked at what happened for the control words. On average, kids only got one control word correct. But you see the range was 0 to 4, and the standard deviation was almost 1. So 5 is one standard deviation outside the range of the control word. So we felt like that was a significant treatment effect, and that's how we would define a good outcome. So now I'll show you this block by block, and I'll just begin here so you can see it. So on the first slide, or the slide on your left rather, we're looking at the percent of kids who got a good outcome, and you'll notice it's not good. So none of the kids in the first block, this is one kid in each intensity, 12, 24, 36, and 48. None of those kids had a good outcome, meaning that they knew 5 or more words. And then over here on the secondary, we're showing the actual number of words learned. So you want to look at the reds, and those are the ones with the numbers over them. So the kid in the 12, he didn't get any words correct. The kid in the 24, he actually got 3 words correct, so he was moving towards that threshold but didn't make it. The kid in the 36 got none of the treated words correct, and the kid in the 48 got 3 treated words correct. The blues are then all of the others, and you won't be able to see them very well, but it's the control words at pre-treatment, the control words at post-treatment, and then the treated words at pre-treatment. If we were getting a good effect, you'd want to see these red bars, you know, rising above the sea of blue, and that would tell you that we're in the right direction. So this did not look promising, but we kept going. And so then in the second block now, where we have 2 kids in each condition, it does look a little better. We are getting a treatment response from half of the kids, so 1 out of 2, in the 24, the 36, and the 48. But you can see that the 12 does not look good still at this point. That was not enough. When we look at the secondary measure, we're getting the kind of curvilinear pattern that we want to see, where the number of words is increasing as the intensity increases. And then as we go beyond 36, it doesn't have any added benefit, and in fact, it's dropping off. The kids might be getting bored with these books. So we see the same pattern at block 3, not much changes. But then at block 4, the pattern changes again, and now we're differentiating the 24 from the 36. The 36 looks like it's has added benefit over the 24, and now the 48 doesn't look like it does have added benefit after you go beyond the 36. And the pattern over here and the number of words correct isn't going to change. It's going to stay this way. And basically the pattern here isn't going to change either as I move through the blocks, but I'll go ahead and show that to you. At this point, at block 5, we decided we could drop intensity 12 because no child had ever responded in that intensity. And so that supported our hypothesis that 12 wouldn't be enough, even though that worked for typically developing children. It didn't work for kids with SLI. And then our numbers go up and down, but the pattern doesn't change. And that's the important thing here, is saying there's no evidence here to really say that going up to 48 gives you better benefit, but there is evidence to say that 36 is better than 24. So that's our preliminary conclusion, is that intensity 36 looks to be the most promising. We see this converging evidence across blocks. And when we look at both the primary and the secondary definition measures, those converge. There's nothing different there. But let's go ahead and look at the naming. So the naming follows the same logic. I'm going to show you just for the final set of kids, the percent that had a good outcome. And so here we chose naming 4 or more words correctly, along the lines of the same logic, that again, the range for the control words was 0 to 3, standard deviation was almost 1, so if you go up to 4, you're about a standard deviation better than what was happening for the control words. I'll also show you a second figure that will show you this kind of pass-through data of what children look like when they're at 12 versus when they're at 24 and 36 and so on. Mm-hmm.
So just a quick question on both of these. So when you're collecting the data, you're bringing in kids in order, right? Do you go back and then reanalyze your data and shift the order of the kids to make sure that maybe kid 5, if you've done kid 5 had come in first, then 3, maybe you might have ended up interpreting the 24 as being better than the 36?
That's the kind of thing we're working on right now,
Yeah.
actually, because in drug trials they do have these kinds of rules. It's
Yeah.
usually more that you escalate as you go, and so it's like you do one intensity and then you put 1 or 3 or 5 kids in, and then if X number respond, you stay. If X number don't, you go up. So there's all these kind of rules of how you escalate in drug trials, and that's what we're working on now, is to do some modeling kind of with our data to see that kind of thing.
Just reshift and pretend
Yeah.
kid 5 was kid 1 and
Yeah.
shuffle the order and go, yeah, it still holds at, I mean, that's great to, yeah, okay.
Yeah, 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 and that's, so we just kind of kept going.
Oh, yeah,
and kind of
no.
felt like this was good, but I think we probably probably could have even stopped earlier too. And that's why we're looking at, would it have mattered which order we went in? Because if it does matter, then maybe you would always need 5 kids or something. 3 isn't going to be predictive or something.
Yeah, no, it's nothing wrong. It could be a stronger test case
Yeah.
too, to say, it doesn't matter what order I put them in, I still come with this amount of exposure.
Right.
Is sort of a cool double check.
Yeah.
Okay, thanks.
Okay, so here's the first measure. This is the one that parallels the definition data, where we're looking at the percentage of children who got a good outcome on this naming measure at their end of treatment. And so you see the pattern is basically the same, although you see their performance is better overall. It's easier to name than it is to provide a really good definition. So we do see some benefit from intensity 12 at this point. But we do see that intensity 36 seems to be the best. It's better than the 24 and the 12, and that as we move into greater intensity at 48, it doesn't seem to convey any additional benefit. And then we can look at these interim naming points, and so you can see how we drop off subjects as we go. So everybody got 12 exposures, and then as we move to the 24, the kids who were just in the 12 didn't get any more, so we lose them. So we lose about 7 kids each time as we move across, and it's noted there. And you can see that the pattern is still basically the same, where the 36 looks to be better than the 24 and the 12. This part is just slightly different in that the 48 doesn't look worse, but it looks as good as the 36. But either way, the conclusion is the same, that doing more didn't convey any added benefit, so it's probably not worth it to do more. So in terms of our intensity then, we think that intensity 36 looks to be the most promising, and so that's the version that we're moving forward with. But in doing so, we also want to look at this variability, because obviously there were some kids who were benefiting and some kids who were not. So that's something we want to look into. So for this, I'm going to focus on that primary outcome measure, the post-treatment definition, except now since we want to look at an individual level, we'll be looking at the number of words with correct definitions. Because there was very minimal response at intensity 12, we'll drop that out. And just look at 24, 36, and 48, because there were some responders there and some non-responders. So then the question becomes, well, what predicts who's going to do well and who isn't in this treatment? And so what we're going to look at for our potential predictors are the pre-treatment clinical test scores that I showed you. And we're also going to look at the naming data from the first naming test. So as a way to kind of look at response to intervention, does how many words you've learned in naming after a limited number of sessions predict your ultimate learning on the definition measure? So first we'll do some correlations, and you see on the chart in red are the 2 measures that had a significant correlation between the measure and the number of words with correct definitions at post. And then in sort of the yellowish brownish color are 3 measures that are above traditional significance, but maybe in sort of a more promising range than any of the others. So there's 5 potential measures here that might be useful. So how can we look at this further? I thought we would look at this as sort of a classification problem. Normally we look at a classification problem in identification. So we think about who has SLI and who doesn't, and how can we predict that. So the classic version is that you have up here something that you know from some gold standard, kids who have SLI and kids who don't, and then you have some measure that you want to use to predict that class or that membership, typically some kind of standardized test. And so kids who perform better than a particular score or below a particular score, you predict to either have or not have the disorder, and then you can look here and see, well, were you right? So for this, now instead of thinking about who has SLI and who doesn't, we want to say who's going to respond to the treatment and who's not going to respond to the treatment. So we know that, get this over here, we know that based on this definition of number of words correct. We've said you've got to have 5 or more words, and so those are going to be the kids who responded to the treatment. And then we have kids who knew less than 5 words, and so those are the kids that we know did not respond to the treatment. So then we can look at all of those significantly or almost significantly correlated measures and identify a cut score on those using ROC curves and the typical things you would do to do that. And then say, well, if you're above that score, I predict that you're likely to respond to the treatment. And then we can see, was that right? And we can also see if you're below that score, we predict that you won't respond to the treatment. And again, we can see, is that right? And you see, typically we're going for a B. We'd like to be 80% correct or better to say that we're in the right ballpark. And we can also look at those two items combined and get an overall accuracy score, and again, you likely want to be more in the 80% or better range there. There are other things you can look at, and I'll show these, but I won't go into it now, but we can look at things like positive likelihood ratios and negative likelihood ratios, and again, that's just telling us something about how accurate we are. For this small sample, it all kind of goes together. So I'll show you these kind of graphs, and they're set up basically like that table just was. So across the x-axis, we have our post-treatment definition score. And so if you're a 5 or better, that means you did respond to the treatment. So all of our responders are over here. And then if you're below a 5, you did not respond to the treatment. So all the non-responders are over here. And then on the y-axis, or the vertical axis, we have a particular score. And the cut score that I selected will be shown here, and it'll be highlighted on the side. So for the Delve Semantic Vocabulary Measure, it was a standard score of 6. If you were at a 6 or better, you were predicted to be a responder. So the upper half are the kids who are predicted to do well with the treatment. And then below are the ones who are predicted to do poorly with the treatment. And so then you can see our sensitivity is pretty good. It meets our standard of 80%. But our specificity is not very good with this particular cut point. And you can see our overall accuracy, we're at a C, so that's not so good.
What did you do with the borderline kids? Which group?
They're in the positive group. So everyone on the line is either a responder or predicted to be a responder. And I should note too that some dots, I didn't actually make the dot size match the number of kids, so if you're trying to count to 21 or something, you won't get there always on some of the figures. But. So same thing now for the non-word repetition score, and you can see here the sensitivity is good, but again the specificity is not good, so it's still not great there. When we move to the phonological memory score, which has non-word repetition as a portion of it, but also adds in a digit span measure, it goes just a little bit better, but still not great. So we still have good sensitivity with the specificity of 4. That's basically the story throughout this, that we can't get good specificity. Phonological awareness actually ends up being the best predictor in terms of the accuracy. So you can see here we've got good sensitivity and good specificity, and our overall accuracy is good, which seems a little weird, but we can talk about that. But that one looks to be the most promising in that regard. And then when we look at the first naming point, we end up with not so good sensitivity and not so good specificity and not great overall classification accuracy. So that didn't look to be as promising as some of the others. So here's the summary going from the ones with the best overall accuracy to the worst overall accuracy with all of the information in between. And so you can see we need more work here. The main point of doing this at this stage was to make sure we didn't throw out measures that might actually be useful, and that we continue to use those measures as we move forward with data collection, and also to give us a chance to think about what are we capturing with these measures, and is there something else theoretically that we think might predict good outcomes that we haven't yet captured. So one thing that we noticed when we looked at this and looked at how these measures correlated with some of the other measures is that the ones in red seem to be picking up on phonological memory, processing, something along these lines. These measures, at least some of them, tended to be correlated with age, and they also tended to be correlated with Bowman-Bristow articulation test scores. So it seems to be some sort of a phonological memory processing kind of factor. Whereas the Delve Semantic and the first naming, those correlated with understanding spoken paragraphs and the overall self-core language score as well. So that green measure seemed to be picking up on something that was more semantics and language related. And that might make sense because to learn a word, you need to know the word form, which is more phonology, and to know the meaning of it, which is more in the semantics and language range. So it might be that there's sort of two factors here, but we need more information to really hone in on that. So in terms of the conclusions, as I mentioned, intensity 36 looks the most promising. We are moving forward with the second step with that intensity. However, we see that we're not getting a majority of children responding at that intensity, so that tells us we need to further enhance the treatment and do some more development. So one of the things we're doing in our current version is we're adding in more expressive elements. You might have noticed that that treatment is completely receptive, and that's how it was done originally. But perhaps at this higher intensity and with kids with language impairments, we really need to ramp up more of the expressive components. They're not just going to get that on their own. We also see variability in the treatment response, so we're going to explore that further in this larger sample where we'll have more kids at that intensity, and that might help us tease this apart. We also did see that there was at least a little promise, not great, but that learning in the first session might be predictive of the outcome. So we're comparing some different ways of getting to 36 exposures, ways where you have more exposures in a session. That maybe that would help if you get learning off the ground right away in session 1, then you'll have a better ultimate outcome versus if your learning is maybe more distributed in time. So we're looking at some of those issues of how we achieve an intensity of 36 and whether kind of having a balance. The 36 right now is 6 exposures in a session and then 6 sessions. But maybe that should be redistributed to really move that forward. In terms of the overall implications for clinical research, I think this escalation strategy looks promising. I think it makes sense to set a minimal acceptable response to your treatment. I think it's good for us to think about that, of like, what would we really want to see out of this? What's the, the rock bottom low where we would say this is moving in the right direction versus we need to scrap this and really totally go back to the drawing board and redesign this treatment. That also still allows for variation, so we can still see that the treatment is not perfect. We can see the percent of children who are responding and see if that seems acceptable, and that can also help us decide if we need to do further development or if we're ready to move forward with a definitive trial. So it succeeded then in highlighting the promising intensity and also shows these areas for further development. And as I mentioned in my response to Julia, we're analyzing our data more to see if we can come up with some rules of thumb for doing this escalation strategy with behavioral treatments, so that we might even be able to be even more economical in the subjects that we use. I also think there's value in examining the treatment response from this classification perspective. That brings it to an area where it might be useful for a clinician to have some idea about whether or not they can predict the success in the treatment, and that's something for us to think about as a field of how we know who will benefit from the treatment and who won't. And I think really it's not sufficient to just show that a treatment works, but there's this added value of knowing for whom it works best and for whom it might not work as well.